think that's the end of this session. We go to the next one.
Dr. Shenaz, who is from Pakistan, she is going to be the moderator for the next session. Shenaz is now become a very good friend. She invited me to Pakistan to hold a workshop many years ago. And she's a professor, head of department, child neurology, Aga Khan University, done a lot of work. And she's the pioneer of the ketogenic diet in Pakistan. So Shenaz, I hand over the floor to you and I will mute myself.
Thank you very much, Dr. Nathan. And first of all, I would like to welcome everybody to this first conference on the ketogenic workshop on the ketogenic diet. And this is amazing work by Dr. Nathan that he has been able to bring all of us together from the South Asia and the Southeast Asia. As Dr. Nathan said, I have been trying to work with the ILAE for the last few years in trying to organize a workshop in Pakistan, but because of the COVID and everything, it sort of fell through. And I think this is the best way of doing a workshop where we can get more participation from all over the region. Again, I will not take up much time, and I will start with the second session of the day. This session is, we'll start off with Dr. Sumita's presentation, which is KD in children, the indications and the evidence of epilepsy. Dr. Sumita is a pediatric neurologist from Malaysia, and she has the boards of pediatrics, as well as she's the member of the Royal College of Pediatrics and Child Health. She has a number of papers where she has worked with children with KD. Her main, the last paper that she has published is a very important one, where she has, given the overall published in epilepsia, where she has published work on KD. So I will, without any further ado, I will ask Dr. Sumita to start her presentation. Thank you.
In this workshop. So my task today is to speak to you about the ketogenic diet therapy in children, indication and the evidence in epilepsy. This is just going to be an overview, but I'll take the opportunity to go in depth into basics of some condition, because I understand not all of us come from a center where we are able to do genetic testing and stuff like that. So my opening statement to you is this. The ketogenic diet is indicated in any form of drug-resistant epilepsy. So what is the definition of drug-resistant epilepsy then? It is defined as a failure of adequate trial of two tolerated and appropriately chosen and used anti-epileptic drug, whether as monotherapy or in combination to achieve sustained seizure freedom. What are the causes of drug-resistant epilepsy? I've simplified and put them into several categories. They include developmental and epileptic encephalopathy, metabolic or mitochondrial disorders, specific genetic condition, superrefractory status epilepticus, structural abnormalities, and other epilepsy syndrome. And this can be further expanded into specific etiologies, of which I would be touching upon in the subsequent slides and talk. So the diet can be used in any form of drug-resistant epilepsy, except. So before we try to understand the indication of the diet, I think it's most important to understand the contraindications first. So the contraindications of the diet can be divided into an absolute or relative contraindication. And the relative contraindication includes an inability to maintain adequate nutrition, a surgical focus identified by neuroimaging and video EEG monitoring, parent or caregiver non-compliance and propofol use along with the diet, because this may cause propofol infusion syndrome, which has a very high rate of morbidity and mortality. With regards to the absolute contraindication, there is fatty acid oxidation disorder, pyruvate carboxylase deficiency, and porphyria, of which I will go into details in the first two conditions. So we start off with fatty acid oxidation defect. Essentially, they are a group of inborn error of metabolism, I think made up of approximately 21 different disorders. There are often two different defects. Number one is characterized by the transport of very long chain fatty acid by carnitine into the mitochondria. And the second defect is in the beta oxidation process. Essentially, what happens is the end product of all these pathways is ATP, or energy. So when there's a defect in any of these mechanisms, there is a reduced production of energy, or ATP, and an excess of the other metabolites, which cause toxicity, which manifests as the following slide in the clinical presentation. So in fatty acid oxidation defect, they can present in the three different age groups. In the neonatal period, they often present in the first few days to weeks of life, and it's extremely fatal. They can have profound cardiomyopathy. You can see I've highlighted, and that's a clue to the diagnosis: hypoketotic hypoglycemia and liver dysfunction. In the infancy and childhood, they can present with intermittent episodes of lethargy, vomiting associated with intercurrent illness, and leads to hepatic dysfunction. Again, hypoketotic hypoglycemia, encephalopathy, and sudden death. And in the adolescent period, it is more of a myopathic type, where they present with muscle weakness, myalgia, and episodic rhabdomyolysis, which can lead to a risk of renal damage. Patients with fatty acid oxidation defect can present with epilepsy. They can have status epilepticus, symptomatic epilepsy, generalized tonic-clonic seizures, and myoclonic seizures. So what is the important biochemical abnormality in fatty acid oxidation defect? The most important is a hypoketotic hypoglycemia. This table represents, so the different carnitine levels might give an idea or a clue as to the different type of the fatty acid oxidation defect, and the diagnosis is often achieved by a DNA analysis. So the bigger question is this: why is the diet contraindicated in fatty acid oxidation defect? It's simply because in this disorder, any state of fasting, a low carbohydrate intake, and a strenuous physical activity causes a metabolic crisis. So number one, when there is no fat, ketones cannot be converted, and therefore there's no ketosis. And like I've said, because the diet is low in carbohydrate, it exacerbates a catabolic crisis and can cause the coma and eventually death. The second most important contraindication is pyruvate carboxylase deficiency. Pyruvate carboxylase deficiency is an extremely rare genetic disorder. And it presents at birth characterized by a failure to thrive, developmental delay, and recurrent seizures. And where is the defect? The orange dancing arrow points at the pyruvate carboxylase enzyme. Therefore, pyruvate cannot be converted and is unable to enter the Krebs cycle, and the end product of the electron transport chain is energy, or ATP. Because pyruvate then is instead converted into lactate, and it causes severe lactic acidosis, and the clinical features are as such. Again, the disorder is also divided into three different forms. Type A is an infantile form, where they develop developmental delay, intellectual disability, mild to moderate lactic acidosis, and ketoacidosis. These are clues to the diagnosis. Abdominal pain, vomiting, tiredness, and muscle weakness. They often die in the infancy or early childhood, but some survive to adulthood. Type B is the severe neonatal form that begins very shortly after birth, again characterized by lactic acidosis, ketoacidosis, hyperammonemia are characteristic. Liver failure, hypotonia, intellectual disability, abnormal eye movements, pyramidal tract signs, seizure, and coma are common, and they also die within the first 3 months of life. And type C is known as the benign or the intermittent form, where affected individuals present with episodic metabolic acidosis. So the biochemical clues in pyruvate carboxylase deficiency include a high pyruvate, lactic acidosis, ketosis, hypoglycemia, and hyperammonemia. An amino acid profile reveals high levels of alanine, citrulline, and lysine, and the lumbar puncture will reveal a high lactate and pyruvate in the CSF. So following are clues as to the diagnosis of pyruvate carboxylase deficiency, including the physical symptoms that I've mentioned previously, 3 different stages, laboratory studies showing high ammonia, pyruvate, lactate, and ketone, and special tests testing the enzyme activity of pyruvate carboxylase in the skin reveals that it's less than 5% of the normal activity, and the diagnosis is confirmed by molecular genetic testing for pyruvate carboxylase gene mutation. So why is the diet contraindicated in pyruvate carboxylase deficiency? Because ketogenic diet aggravates metabolic acidosis and it causes life-threatening coma and death. Now we move on to the indications of the diet. This is a pivotal paper published in 2018 by the International Ketogenic Diet Society. The indications are taken, in the subsequent slides are taken from this very important paper. So the indications of the diet can be divided into 2 groups. One is the group that is responsive, 60 to 70% responder rate. Previously, responder rates were defined as more than 50%. Multiple reports with at least 3 publications from at least 2 ketogenic diet centers. For the ease of understanding, I divided them into several groups, including specific genetic syndromes like Angelman syndrome, mitochondrial disease, complex 1 mitochondrial disease, metabolic diseases, GLUT1 deficiency syndrome, and pyruvate dehydrogenase deficiency, developmental and epileptic encephalopathy, including previously known as Ohtahara syndrome, West syndrome, epilepsy with myoclonic atonic seizure or DUSE syndrome, Dravet, and TSC, and in super-refractory status epilepticus, in particular, bias. The second group are those with moderate benefit from the diet reported as no better than 40 to 50% responder rate. The conditions are as listed in table 2, but in the interest of time, I will just focus on Lennox-Gastaut syndrome and cortical malformation. We start off with one of the most important or the clear indications of the ketogenic diet, which is an important cerebral energy metabolism disorder, which is GLUT1 transporter deficiency and pyruvate dehydrogenase. I will just touch briefly, as there are other speakers who will dwell upon the details later on. So what is GLUT1 or glucose-1 transporter deficiency syndrome? We all know now how important glucose is. Essentially, it is the fuel to the developing brain. So glucose is transported via the GLUT1 transporter, which is located in the blood-brain barrier to the brain. And SLC2A1 codes for the GLUT1 transporter. So when there is a defect, it is no-brainer, glucose cannot be transported, and it causes a cerebral energy crisis. Diet works by producing an alternative metabolic pathway by producing ketone, and ketone is transported across by another transporter, MCT1, encoded by a different gene. GLUT1 deficiency presents with a triad, or rather an age-specific presentation, often early onset epilepsy, progressive cognitive and behavioral disturbances, and later in life, around the adolescent period, movement disorders start off and progress towards the adulthood. What are the clues to the diagnosis? Often they have infantile onset epilepsy, a deceleration of head growth. The picture tries to depict a paroxysmal eye-head movements. I apologize, I don't have a video. Subsequently, developmental impairment becomes increasingly apparent, and complex movement disorders, including ataxia, paroxysmal exertional-induced dystonia, starts off in the late childhood and adolescence. The diagnosis can be suspected easily or confirmed by a low CSF glucose, a low to normal CSF lactate, and a normal serum glucose and lactate. And the diagnosis is confirmed by a pathogenic mutation in the SLC2A1 allele. So we move on to what is the evidence of the diet in GLUT1 deficiency. Now, this was one of the largest series published by CARS. There were 92 families, of which 98% of them were treated with the diet, with a mean duration of 5.5 years. And they found that 95% of the children had 50% seizure reduction, of which 80% had 90% seizure reduction, and 64% of them subsequently were not receiving any anti-seizure medication. With regards to the type of ketogenic diet, classical ketogenic diet at 63% was most commonly used, followed by the modified Atkins diet at 31%. Now, this is the recommendation by the International GLUT1 Deficiency Study Group. They stated that the diet remains the treatment of choice in GLUT1 deficiency syndrome and should be started as early as possible. In children under the age of 2, a classical 3:1 ratio is the treatment of choice. Most centers continue to try to obtain a high degree of ketosis to meet the energy demands of the developing brain. Most centers also believe that the modified Atkins is a good alternative to the classical diet. So we move on to pyruvate dehydrogenase deficiency. Now, in this deficiency, the arrow points to there's a defect in the pyruvate dehydrogenase complex. So pyruvate is unable to enter the Krebs cycle and produce energy. And it results in severe lactic acidosis, seizures, and severe encephalopathy. And again, the diet provides an alternative pathway by providing ketone as an alternative cerebral fuel for the developing brain. So what is the evidence of the use of the diet in pyruvate dehydrogenase deficiency? This was a study looking at the short and long-term effect of the diet. There were 19 patients with a median age of 6 on the diet for about 2.9 years. And 50% of them had seizure freedom within 1 year of initiation of the diet. Now, besides them, what's most striking is the positive effect of the diet in other areas, including ataxia, sleep disturbances, speech and language development, social functioning, and frequency of hospitalization. We move on to the second group of disorders known as complex 1 mitochondrial disorders. So this is a very heterogeneous group of disorder, and it's a defect in the respiratory chain or the electron transport chain, which is the final pathway for the generation of ATP via the oxidative phosphorylation. This disorder affects anybody at any age, and any organ, but the organ most affected would be the brain and muscle because they're highly dependent on oxidative phosphorylation. And the common features in this disorder includes proximal myopathy, external ophthalmoplegia, seizures, dementia, ataxia, deafness, retinitis pigmentosa, stroke, and diabetes mellitus. Epilepsy is a common presenting feature, and it can be extremely challenging to manage in complex 1 mitochondrial disorder. So adults often present with more recognizable syndromes as shown in table 1. Disorders like chronic progressive external ophthalmoplegia, MELAS, and MERV are probably not uncommon to us. But presentation in children are said to be more non-specific, and the nervous system is the most commonly affected system in mitochondrial disorders. Approximately 45% of children present with neurological signs. The following are the common neurological signs: muscle weaknesses, proximal more than distal, upper more than lower extremities, hypotonia, peripheral neuropathy, ataxia, ptosis, ophthalmoplegia, and the others. So with such a vast and vague presentation, now how do we suspect a mitochondrial disease? So clues to a possible respiratory chain defect may be a short stature, sensory neural hearing loss, progressive external ophthalmoplegia, axonal neuropathy, diabetes, hypertrophic cardiomyopathy, and renal tubular acidosis. A high index of suspicion, I like this line, should be suspected in those with either a multi-system involvement or a single system involvement without a clear explanation. And although non-specific, any unexplained elevation of lactate in any tissue, blood, or cerebrospinal fluid should raise the suspicion of a mitochondrial disorder and warrants further evaluation. What is the evidence with regards to the use of diet in respiratory chain complex defect? This was a paper published by Kang in 2006. There were 14 patients with different defects in different complexes, but predominantly 9 in complex 1 defect. And you would see 2 out of 3 in complex 4 defect evolve into ILAE syndrome or ILAE syndrome. The common epilepsy syndrome included infantile spasms and Lennox-Gastaut syndrome. And what Kang found was 50% of them had seizure freedom. We move on to the third disorder, which is a huge umbrella of developmental and epileptic encephalopathy, also known as DEE. So the question is, what is DEE? Essentially, developmental and epileptic encephalopathy is characterized by drug-resistant epilepsy and encephalopathy, which encephalopathy is defined as significant developmental delay or regression. Often, there is an underlying genetic etiology, and this genetic etiology is the underlying cause for the encephalopathy or the direct cause for the encephalopathy, and the drug-resistant epilepsy is only a confounding factor. So why is this important? Is because we now understand that early treatment can improve the developmental outcomes. This will be spoken to you in detail by the next speaker, so I'll just roughly touch upon it. West syndrome. In the latest 2022 classification, it is now known as infantile epileptic spasm syndrome, which comprises of a triad of infantile spasms. Let's watch the video first. So there you go. You see an infant with asymmetrical spasms, and subsequently cries, is a little bit irritable, and the same asymmetrical extension of this leg will occur shortly. There. So spasms are characterized by clusters of either asymmetrical, symmetrical, flexion, or extension, which occur upon transition states, either upon awakening from sleep or getting up from sleep. The EEG is described as hips arrhythmia. It is a chaotic pattern made up of high amplitude polymorphic delta and mixed sharp and spikes with developmental delay or regression. What is the evidence of the diet? What is the evidence of the diet in epilepsy, in infantile spasm? So often the first line treatment for infantile spasm are steroids, on our side at least, and followed by vigabatrin. So this paper looked at the efficacy of the diet after failing 2 first-line drugs. Hong et al. In 2010, Parisio and Parisio as well looked at 13 papers, and they found 65% of them had 50% spasm reduction by 6 months. So then the question is, why not use the diet as first line? There was a paper published in 2005 by Rubenstein, but there was only 2.8% of patients, 13 out of 460, who used the diet as first line, and they found that 50% of them had seizure reduction at 6 months. So has there been a head-to-head comparison between ACTH and the ketogenic diet? The answer is yes. Dr. Kassoff published this paper in 2008 looking at comparing between the effects of the diet as first line versus ACTH. And what he found was that what the spasm freedom rate and the electroclinical remission at 1 month was much higher at 90% and 53% in the ACTH group versus the ketogenic diet group. But the ketogenic diet group had very minimal side effect and a much lower relapse rate. With that, it's probably safe to say that the steroids or ACTH dampen seizures faster, but the diet can be considered earlier, either as second or third line medication for infantile spasms. The second disorders in Dravet syndrome, the second disorders under the developmental and epileptic encephalopathy is Dravet syndrome. Dravet syndrome is caused by an SCN1A mutation in 80% of the patient. It's often a de novo mutation. It starts at about 5 to 8 months of age in a previously normal infant. They often present with prolonged generalized tonic-clonic seizures, hemiconvulsion, alternating hemiclonic seizure with or without fever. They go on to develop other seizure types, including myoclonic, atypical absences, focal or atonic seizures. The EEG is often normal in the first 2 years of life, so is the MR or MRI brain, and developmental delay often starts in the second year of life. Later on, they go on to develop ataxia and spasticity. This was a paper published by a Yokohama group. I find this quite useful. So it's a predictive scoring for those less than 1 year of age to see who has a high risk to develop Dravet syndrome, or rather who you should send for SCN1A mutation. So the following are the risk factors. And a total score of 6 or above is highly indicative of Dravet syndrome. So what is the evidence of the diet in Dravet syndrome? Carabello published 2 different papers, one analyzing the use of the diet in a year and the other over 2 years, and there was not much difference. The seizure freedom rate was between 12.5 to 15%, and 75 to 99% seizure reduction was seen in about 60% of them, and more than 50% seizure reduction was found in approximately 25% of them. This was a paper published by Dressler comparing the efficacy of the diet with various standard anti-epileptic drug use. And the responder rate, they looked at responder rate at 3 months. You can see the diet had 70% responder rate versus the usual combination of stiripentol, sodium valproate, and clobazam in 89%, not differing significantly, and bromide at 78%. What is more important is the diet was much more well tolerated with very little compliance issue. It was very effective in status epilepticus and prolonged generalized tonic-clonic seizure and myoclonic seizure. And therefore, they concluded that the diet should be considered earlier in infancy to reduce mortality and morbidity and to ameliorate cognitive outcome. The responder rate at 3 months was 70% with the use of the diet and 60% at 12 months of age. This was a recent publication in 2020, essentially a meta-analysis by Yan et al. And he pretty much found the same finding that at 6 months, the 50% seizure reduction rate was 60%. So we move on to the third important syndrome under DEE, which is epilepsy with myoclonic atonic seizure, previously known as myoclonic astatic epilepsy or DUS or DUSE syndrome. It affects boys more than girls. They often present at 1 to 5 years of age at a median age of 3 years old with a normal development prior. So they can develop myoclonic atonic seizures. They may have other combination of generalized seizures, including tonic-clonic absence and non-convulsive status epilepticus. 40 to 60% of these children have febrile seizure before the onset of their epilepsy. The etiology of myoclonic atonic epilepsy is not known, and imaging of the brain is often normal. It's highly associated with generalized epilepsy with febrile seizure plus and the SLC2A1 glucose transporter gene that I spoke about before. I'll play you a video. You need to watch it. I'll play it again for you. Essentially, watch her left hand. She jerks, she drops her phone, and then she slumps forward. She loses tone, and that's atonia. I'll play it again for you. Sorry. right? It's really fast. I apologize, the quality of the video is not very good, but that's how myoclonic atonic seizures are. And the EEG is characteristic. At the onset of the myoclonic seizure, what you see is generalized polyspike and wave. And EMG is very important. The red arrow shows a slow wave during the period of atonia. Often these patients have a lot of injuries in their forehead, as depicted by the picture below. And a safety helmet is very important in these children. So what is the evidence of the diet in epilepsy with myoclonic atonic seizure? These three following authors concluded that the diet was most effective in stopping seizures followed by ACTH and ethosuximide. And in their cohort, 68% of their patients achieved complete remission. This was an experience by the Children's Hospital of Philadelphia. Essentially, what it tries to tell you is the diet is often the last treatment, the last go-to treatment. But the highest seizure freedom rate was with the ketogenic diet, with 50% achieving seizure cessation for at least a month and 30% achieving seizure cessation for 6 months or more. The seizure freedom rate from the ketogenic diet in this disorder in general ranged between 50 to 20%, corroborating with prior observations with the use of KD. This is a paper recently published in 2021, essentially looking at the use of the diet versus first-tree anti-seizure medication. You can see that 79% of the patient had more than 50% seizure reduction with the diet, versus only 26 with first-tree anti-seizure medication. With that, we can conclude that the diet therapy is most effective treatment in epilepsy with myoclonic atonic seizures. And furthermore, normal development or delay in only one domain was found in 59% of the patients. Lennox-Gastaut syndrome is an important developmental and epileptic encephalopathy as well. It is also characterized by a triad of multiple seizure types, of which tonic seizures is a prerequisite. They have a characteristic EEG pattern of sudden bursts of diffuse 1.5 to 2 Hz slow spike and wave discharges, which are greatly activated in sleep with developmental delay or regression. The evidence for the use of the diet in Lennox-Gastaut syndrome is this was an early paper in 2012 by Lamont, who found at least 51% of them had 50% seizure reduction. And later, Dr. Kusov also corroborated the same. He also found at 6 months, at least 50% of them had 50% seizure reduction. We go on to, I think this must be the third or fourth group, which is super refractory status epilepticus. Now, definitions are very important, so I will take some time to define the following. We know now status epilepticus is defined as seizure activity lasting for more than 5 minutes. Refractory status epilepticus is continuous seizure despite the use of an initial benzodiazepine and an acceptable second-line intravenous anti-epileptic medication. And super refractory status epilepticus is a continuous refractory status epilepticus despite the use of anesthetic agent. Now, super refractory status epilepticus is a neurological emergency. About 23 to 48% of status epilepticus evolve into refractory status epilepticus, and 22% of refractory status epilepticus evolve into super refractory status epilepticus. The mortality and the morbidity rate is very, very high if it's not recognized early. These are the common causes of super refractory status epilepticus, including infection, autoimmune encephalitis, brain malformation, genetic conditions like PCDH19 girl clustering epilepsy or Dravet syndrome itself, metabolic disorders, and Alpers disease. When this etiology has been ruled out, 2 other conditions must come to mind, including fires and NOS. Now, NOS is a clinical presentation and not a specific diagnosis, and it occurs in a patient without active epilepsy or pre-existing neurological disorder, with new onset of refractory status epilepticus without a clear acute or active structural, toxic, or metabolic cause. And that's why the previous slide was important. FIRES, on the other hand, is a subcategory of NOS applicable for all ages, requiring a febrile infection between 2 weeks and 24 hours prior to this onset of refractory status epilepticus, but the fever does not have to occur at the onset of status epilepticus. The diet provides a class 4 evidence with its use in superrefractory status epilepticus. The following are evidence of the use in superrefractory status, especially in FIRES. I think Park et al. In 2019 had the largest amount of patients, which was 16. 10 out of 16 of them had FIRES, and you will find that he achieved ketosis within 2 to 6 days. More than 50% of them had seizure freedom, and 37.5% of them had 50% seizure reduction. The diet is well tolerable with very minimal side effects. The next group of disorders are known as tuberous sclerosis complex. Tuberous sclerosis complex is an autosomal dominant disorder, and the mutation is on TSC1 gene, which codes for the protein harmatin, and TSC2, which codes for tuberin. These two proteins are very important because they inhibit the mTOR, which stands for the mammalian target of rapamycin. A loss of function in these two genes leads to excessive cell proliferation and unregulated cell growth, which manifests as the following in the next slide. These are the multiple clinical manifestations of tuberous sclerosis complex over time. Essentially, rhabdomyomas can be found in the prenatal scan. Cortical tubers, subepidermal nodules, and sega can also be detected early, especially in the infancy. Dermatological manifestation, Ashleigh macules, can be found during infancy and should be looked for. Facial angiofibroma starts around the age of adolescence. Retinal hematoma starts during the childhood. Angiomyolipoma of the kidney starts in adolescent, and LAM is essentially found in adult patients. This is a diagrammatic representation of what I've just said to you. So cardiac rhabdomyoma, that's a cortical tuber followed by a subependymal nodule and a very large sega. Under the ophthalmological manifestation is your retinal hematoma. You have Ashleigh macule, a chagrin patch, and a facial angiofibroma. The CT is showing you AML or angiomyolipoma, and the lung CT is showing you a LAM. So seizures, despite the multi-system involvement in tuberous sclerosis, seizures are the biggest problem of all. About 80 to 90% of children present with seizures, especially during the childhood. 1/3 of them develop infantile spasms. And tuberous sclerosis accounts for 10 to 20% of the total estimated case of infantile spasms. So it's always imperative to rule out tuberous sclerosis in any child that presents to you with infantile spasm, because the drug of choice often differ. We often use vigabatrin as our first-line drug for infantile spasms with tuberous sclerosis. And if that fails, we go on to try steroids. And besides infantile spasm, they can have other seizure type, especially focal seizure, and it's not uncommon for them to also have generalized seizure. Now, when patients with tuberous sclerosis have focal seizures and they are concordant with the EEG and neuroimaging, then they become very good surgical candidates. This is one such example of our patient, a 3-year-old boy with underlying tuberous sclerosis complex, seizure onset at 9 months of age, with very stereotypical head extension, eye deviation to right. The arrow tries to point to a left facial paresis and left arm dystonic posturing. The ictal EEG shows ictal rhythm arising from the right anterior quadrant, and the MR shows you a precentral gyrus tuber, which was concordant with his PET scan. So he underwent a tuberectomy and he remains seizure-free. But this is not the case for all patients. So what happens if they fail surgery or they are not good surgical candidates? That's where the diet comes. So the evidence of use of the diet in tuberous sclerosis date back to 2005. This was a very small cohort of 12 children. And at 6 months of diet, he found that 92% of them had 50% seizure reduction. and 67% had 90% seizure reduction, and 5 had 5 months seizure freedom. This is a much larger paper found this year in 2022 by Yu Fang in China, who had 53 children. And he found that the 50% seizure reduction rate was anywhere between 43 to 51% in the first 6 months, and the seizure freedom rate was between 17 to 21% in the first 6 months. But what's more impressive is 70.6% of them showed cognitive and behavioral improvement. Now, this is the last group of disorders that I will touch upon, which are the structural epilepsies, cortical malformation, and acquired structural epilepsies. This was a paper published by Carabello looking into the use of the diet in children with intractable epilepsy secondary to malformation of cortical development. It was between 2 centers, I think Argentina and Italy. He divided them into 3 groups, which is group 1, an abnormal neural proliferation, example, hemimegalencephaly. Group 2, abnormal neural migration, example, Lees-1 or Leesencephaly. And group 3, which is your abnormal post-migrational development, example of which are your schizencephaly and polymicrogyria. Of 45 patients on the diet between 4 to 96 months, he found 44% of them had a seizure reduction of more than 50%, and 4.4% of them were seizure-free. And this was a recent publication in 2020 by a group in China who looked at the efficacy and tolerability of the diet in Chinese children with drug-resistant epilepsy secondary to structural etiology. He divided them into 3 groups. Group 1 was the neonatal brain injury, group 2 intracranial infection, and group 3 malformation of cortical development. And of 23 patients, the responder rate at 3 months was 60%, at 6 months 52%, and at 12 months 47.8%. Amongst the 3 groups, the group that had higher responder rate was group 1, the neonatal brain injury at 75%, versus 60% in the intracranial infection, versus 33% in the malformation of cortical development. And the group with HIE had the highest responder rate at 100%. The following are indications of the diet in other conditions that I did not speak about, but I will just mention. Angelman and Ohtahara syndrome have strong indications for the diet. Those with moderate indication include Lafora disease, Rett syndrome, Landau-Kleffner syndrome, and SSDE. Single case reports in the following disorders, and limited data in juvenile myoclonic epilepsy, CDKL5, epilepsy of infancy with migrating focal seizure, and childhood absence epilepsy. The conclusion from the International Ketogenic Diet Society in 2018 is this: the diet is strongly considered in children who have failed 2 anti-seizure drugs. I've mentioned before, this is drug-resistant epilepsy. It is the treatment of choice for 2 specific disorders of brain metabolism, which is GLUT1 deficiency and pyruvate dehydrogenase deficiency. For Angelman syndrome, Dravet syndrome, Fires, infantile spasms, epilepsy with myoclonic, atonic, and tuberous sclerosis, the diet should be offered earlier. There is mixed opinion with regards to the use of diet in a clearly approachable surgical lesion. And before starting the diet, one should consider inborn error of metabolism that can lead to severe metabolic crises. I end by saying this. This is my take-home message for you. The diet essentially can be used in any seizure type. The diet can be used in any epilepsy type and in any epilepsy syndrome with any etiology. But we first must rule out absolute contraindications first. With that, I thank you very much for listening.
Thank you very much, Sunita, for an excellent presentation and an overview of the use and indications of ketogenic diet. We will go on to the next presenter, who is Dr. Samar, and she will be presenting on the ketogenic diet in infants, indications, and the evidence in epilepsy. Just a reminder for everybody who's attending this session to put your questions in the chat box, and we will be taking the questions at the end of the session. So Dr. Summer is a pediatric neurologist and from UAE. She is currently working at the she's working in Dubai, and she is a member of a number of organizations, has a number of years of experience. She's currently working at Jalila Hospital, Dubai, and also previously worked at Latifa Hospital for Women and Children in Dubai. So she has a huge experience in working with children, especially with epilepsy. And without further ado, I would like to invite her to start off the presentation. So Dr. Janak, if you want to put on her presentation, we can try this again. If it doesn't, then we'll ask her to do it like Sumita did. Thank you.
Yeah, I'm just trying to put on her recording. Just give me a minute.
Go ahead.
No, not me. The video is going on.
No, we can't.
Okay, right. Okay, then I'll stop it.
I think you'll have to just play your PPT and do it.
Yeah, better.
There's some reason why the ILAE only videos work, no audio. I'll have to check with them.
So without further delay, let me start my presentation about ketogenic diet in infants. So as we heard from
Dr.
our
Samar,
yes?
can you speak a little louder?
Okay, can you hear me right
Okay.
now? 'Cause
Yes.
I'm talking through microphone, yeah.
Yes.
So ketogenic diet in infancy. So as we heard by our, just a second. Yeah, so as we heard by our previous speaker, ketogenic diet is a well-established, effective non-pharmacological treatment option of drug-resistant childhood epilepsy since the 1920s. It is used in children after 2 to 3 anti-epileptics drug failure, and earlier in some epilepsy syndromes, as we will be discussing in the following slides. So infants are a vulnerable population with specific nutrition requirement. For a long time, ketogenic diet was not recommended for use in infancy. And because of this, such crucial period in development and perceived high risk of nutritional inadequacy. Managing epilepsy in infancy also is challenging based on the characteristics of the epilepsy itself and the impact of on the neurodevelopment. Now, current research shows, as we are going to see, that ketogenic diet is highly effective and well tolerated in infancy with refractory epilepsy syndromes. So I'll be talking only about infantile spasms, Ohtahara syndromes, and epilepsy of infancy because my colleagues has already spoken about the rest of the syndromes. So we'll start with Ohtahara syndrome, which is a rare epilepsy syndrome that's seen in infancy. It is also called early infantile epileptic encephalopathy with birth suppression, where the seizure begins before the age of 3 months. Babies basically have severe developmental challenges and abnormal neurological examination even before the start of the seizures, and the motor and cognitive problems will carry on with the seizure increase. Now, there are many types of seizures in Ohtahara syndrome, but tonic seizures or stiffening of the arms and legs are the most seen. These seizures lasted for only seconds, and that can occur in clusters and many unilateral. Other types of seizures may include focal seizures, atonic, myoclonic, and generalized tonic-clonic seizures, and eventually these children may develop infantile spasm with growing age. Most common causes of Ohtahara syndrome are brain malformation and some genetic mutations. That includes the mentioned types, basically the channelopathies. Metabolic causes are less likely, and in some cases there is no clear cause. Now, I'll skip this slide. The EEG is the most important test in making the diagnosis of Ohtahara syndrome, along with the clinical features. The EEG is very abnormal, that showing burst suppression pattern with high amplitude spikes followed by little brain activity or flattening of the brain waves. MRI is required to look for structural changes in the brain, genetic testing along with whole exoming if the MRI didn't show any finding, and blood and urine tests to evaluate metabolic disorders is reasonable. Now, anti-epileptic medications are routinely used, but the seizures with Ohtahara syndrome are usually drug resistant, and epilepsy surgery may be an option in children with seizures starting from one area or involving one side of the brain. In that situation, a focal resection or hemispherectomy should be considered. And ketogenic diet may be considerable if the seizures are drug resistant and the child is not a candidate for epilepsy surgery. Now, the outlook of patients with Ohtahara syndrome may be grim. Many children progress to infantile spasms or Lennox-Gastaut. Some of them will die within the first 2 years of life. And those who will survive will typically left with severe physical and cognitive disability. Now, in terms of the evidence of the use of the ketogenic diet in Ohtahara syndrome, there is only case reports that I could find, and all of them concluding that ketogenic diet is effective in the treatment of Ohtahara syndrome. Second thing is we'll talk about is infantile spasm syndrome, which is a catastrophic infantile epileptic encephalopathy. Again, it's a triad of, we call it West syndrome, if it has the triad of the three mentioned previously in the previous lecture. The clinical spasms, which is flexor extensor spasms, plus the abnormality in the EEG, which is called hypsarrhythmia, plus the developmental stagnation or regression. Now, it was first described in 1841 by Dr. West, and these seizures may be subtle and can be confused with the normal baby behaviors or colics. And it can appear in different ways. Sometimes it's called flexor spasms or jackknife seizures due to their appearance. They are consistent of a sudden stiffening with the arm flinging out as the knees pulling up and the body bends forward. Less often, the head can be thrown back as the body and the legs stiffen in the straight out position. Movements can also be more subtle and limited to the neck or other parts of the body. Infants can cry out during it or after the seizure. It is relatively common, and the onset is considered an age-specific epilepsy, and the onset can be between the age of 3 to 12 months, characterized again by the clusters of flexor, extensor, or mixed myoclonic jerks, and it may be associated with autonomic or focal seizures. Now, what causes infantile spasms? 2 out of 3 patients with infantile spasms have some known cause of seizures. However, the range of causes is broad. The most common cause is structural change in the brain that may be due to a prior injury, such as brain infection or lack of oxygen to the brain. And it's also due to change in the way the brain have developed, like cortical malformation or dysplasia, Genetic causes are also a possibility, and there is a number of genes associated with the spasms. Metabolic causes can also lead to changes in the brain function and can cause spasms. There is no evidence that the family history or the baby sex or factors like immunization are related to infantile spasms. Now, how to diagnose infantile spasms? A careful history of the spells, including how they look. A home video is extremely useful if the verbal history is unclear. Physical examination and physical and neurological examination is very important, looking for neurocutaneous markers or clues for the diagnosis. An EEG, An EEG looking for the electrical activity of the brain is important, and most infants diagnosed with infantile spasms will need other tests like MRI to rule out brain structural anomalies, plus urine and blood tests for metabolic causes. Here is an example of infantile spasm in a patient with hydrocephalus, where you will see him having clusters of flexor spasms. I hope the video is clear. Another example, but with a different etiology, neonatal stroke. And sometimes it's very subtle, where only his eyes are rolling up. Here is an example of an EEG for the electrical activity of the brain, showing a pattern that's called hypsarrhythmia, where the seizures are not occurring with the high voltage spike waves pattern, and it's often helping in confirming the diagnosis. And this is the ictal part of it, with the spikes followed by electrodecrements. Now, managing infantile spasms, so it is essential to be treated as quickly as possible with the most effective therapy. And trial of the therapy includes steroids and vigabatrin, as mentioned earlier. Studies show that if combining combining steroid and vigabatrin may be effective for controlling the seizures and for the development in long term. However, if the infantile spasms continue despite the treatment with the steroids and vigabatrin, children should be seen in a pediatric epilepsy specialist to consider best course of treatment. Now, if the medication did not go, they are candidate to be for epilepsy surgery if there is a cortical dysplasia or brain focal lesion. Ketogenic diet has been reported to be safe and well tolerated as well in treating children with infantile spasms if it's not responding to steroid or vigabatrin. The outlook is brighter for children who develop normally before the start of the, if they are developed normally before the start of the spasms. However, most of the children with infantile spasms, they become intellectually disabled later on in life, and they have a higher chance to have a moderate to severe developmental delay, and they may develop autism as well. Lennox-Gastaut and focal or other multifocal epilepsies also might develop. Thus, the treatment of seizure as early as possible is critical. The third is epilepsy. The third syndrome we are going to talk about is epilepsy of infancy with migrating seizure, which is a very rare form of epilepsy. Typically, age of onset is before 6 months of age, and it's equal between boys and girls. Now, the seizures are characterized by focal tonic or clonic seizures that involves the arms and eyelids, where the head turns to one side. Seizure might also be difficult to be detected clinically with subtle behavioral arrest. The characteristics of the seizures is that it's moved from one lobe of the brain to another and from one hemisphere to another. And it's only going to be witnessed or evidenced if an EEG is done during the seizures. Though the seizures might be infrequent at the start, they may quickly evolve to be frequent daily prolonged seizures with status epilepticus. The cause of epilepsy is often unknown. Most common cause is genetics with channelopathies. And rarely these syndromes can be associated with congenital disorder of glycosylation. How to diagnose? It's based on, again, characteristics, history, and EEG, where the EEG will be normal at the beginning. However, the background becomes slow over time with multifocal spikes. Recording of the seizures in the EEG is very helpful to show the characteristics migrating pattern. Genetics testing is important, and MRI scan usually normal at the start, but eventually it shows you how the brain become progressively abnormal. Seizures tend to be resistant to anti-epileptic medications, and children with epilepsy of infantile with migrating focal epilepsy are frequent and multiple happens multiple times during the day. Usually it is resistant, as we said, and ketogenic diet has proven to be an option for this treatment, where receptive brain surgery is not usually an option. Children may be developing normally at the onset, but with frequent seizures, regression or lack of progression will result in severe developmental disability later on. Patients can also be affected by gut dysmotility and movement disorders. Again, it's only case reports that I found regarding infancy with migrating focal seizures that supports the use of ketogenic diet, and it shows that it's safe and effective in each article. Now, the classic ketogenic diet has been used continuously since, as we said, 1920s. Over the years, it was difficult to implement the ketogenic diet due to lack of the consistent of guidelines. Now, national guideline was attempted in Germany once, and recognition of the value of this document led to the desire of create similar international guidelines, where in 2019, the expert of consensus guidelines has been developed. Now, it was already discussed in 2006, and the Charlie Foundation commissioned a panel compromise of 26 epileptologists that led to this, to make this guidelines that was endorsed by the Child Neurology Society. And again, it included 26 clinicians from 9 countries, and they had a short survey that they answered 15 questions, and they put all this recommendation to help state-of-art protocol and standardized ketogenic diet for multi-center clinical trials, and then identifying areas of controversy and uncertainty for future guidelines. That has been updated after 10 years, where 31 clinicians has been included in that. Around 17 were outside the USA, and 6 dietitians were involved. The survey at this time included 20 questions, and it was endorsed by the Child Neurology Society, Charlie's Foundation, and Matthew's Friends as well. And this recommendation, that's how they selected the ketogenic diet. As we all know, it is effective to treat epilepsy individuals from infancy through the childhood. So, and they strongly advocate to be considered as early as possible an option for treating difficult to manage epilepsies. There's one article that showed that they use the ketogenic diet as early as 6 weeks in neonates. Now, the majority of the consensus, 96%, believe that ketogenic diet should be started first line in GLUT1. And I believe my previous colleague has explained most of these examples. And we're just highlighting that it includes the high recommendation, and response rate more than 70% was also found in our cohort of patients of infantile spasms, Ohtahara, and formula-fed infants. multiple papers I found regarding or supporting the use of ketogenic diet with proper efficacy and safety in younger age. Just want to a little bit discuss this case in more details. It's a paper published in 2015 in Austria to evaluate the efficacy and safety of ketogenic diet in infants who are less than 1.5 years of age compared to older children above the 1.5 years of age. So they compared patients. First, they took the patients who completed follow-up data of more than 3 months after initiating the ketogenic diet and analyzed it retrospectively. And they have made 2 groups. So the infants were group A, and they compared it to children, and they called them group B. Now, around 127 patients chart screened between the years of 1999 to 2014. 115 were included and were distributed equally between the groups. 3 were excluded because of the infants were refusing the food, and one of them was having incompetence of caregiver. The classic ketogenic diet was used in the most of the patients. The mean age of initiation was around 2.8 years, and the mean age of initiation was in more than 1.5 years of age, around 50%. The clinical, again, this is the cohort of patients with their underlying etiology that has been included in the paper, and the majority was having structural and metabolic disorders followed by unknown ages. The baseline was seizure frequency 3 months before the initiation of the diet. Treatment response was defined as absolute reduction of the seizure frequency more than or equal to 50% of at follow-up of compared to baseline, and safety was evaluated using the standardized routine medical examination and parenteral review for the efficacy, parenteral side effect questionnaires, and labs and tests according to the international guidelines. And in terms of the efficacy, they found at 3 months of age follow-up, 61% were responders and 26 were seizure-free. And there was no significant difference between infants and older children with respect to response rate, but more infants or group A become seizure-free at 3 months of age. At 6 months of age follow-up, the responder rate was around 54.7%, and at 12 months of age, around 48%. Again, there was no significant difference between the groups with respect to the response at 6 and 12 months, but more infants were seizure-free in both groups. The majority of the patients were suffering from infantile spasms, followed by Lennox-Gastaut. In terms of the safety, at least one side effect was seen in 52 out of 115 of the children, including the above mentioned side effects. Only one infant of the diet was withdrawn because of the hyperglycemia. No other side effects that made necessary interruption or withdrawal from the ketogenic diet were observed, and no significant difference between group A and group B was observed. And in terms of the compliance, it was already mentioned that 9 children were dropped out of the study at the first few days after initiating the ketogenic diet. 2 of them only were infant. They concluded that ketogenic diet is effective and safe to be used in infant, and therefore to be considered early during the course of epilepsy rather than at the last option only. And the eating habits during the first years of life permits an easy introduction of the ketogenic diet with liquid formula in this age group, especially in infants with infantile spasm, Lennox-Gastaut, and partially epilepsy. Efficacy of the ketogenic has been shown high. And as seizure freedom is essential for developmental outcome in infancy, the early use of ketogenic diet seems to be as effective a treatment option. Another study I have found, again, supporting ketogenic diet efficacy and safety during infancy. I found this literature review again, and involves also infants between the age of 0 and 23. And it has 52 publications. 4 of them were randomized controlled trials, and they showed that ketogenic diet and its variant are safe and to be used between the age of 0 and 23. And again, classical ketogenic diet is of the first choice in the treatment of GLUT1 deficiency, and to be used as early as possible. These are my references. Thank you very much. I know it has been a pleasure for me now to be with you in this conference. Thank you very much. And if there is any question, please let me know at the end of this session.
Thank you very much, Dr. Samar, for a very impressive overview of the role of KD in infants. And we all know how difficult it is to control the difficult epilepsy, especially the infantile spasms and the otohara. And you presented excellent the way that the role of KD can be used. I would like to now ask our third presenter, and he needs no introduction. Dr. Nathan is well known to all of us. He, for me, is the key person who started ketogenic diet in South Asia and Southeast Asia. He is currently a consultant at Shirusha Citizens Cooperative Hospital. He's also an honorary professor at the Patel Medical College in Pune. And as I said, he's the pioneer for ketogenic diet. And without he's also the executive committee of the International Neuroketogenic, member of the executive committee for the Neuroketogenic Society. So without taking up too much time, I would like to invite Dr. Nathan again for the second session of this day for his presentation on the role of KD in in adolescent and adults, the indications and evidence in epilepsy. Thank you.
Thank you, Shahnaz. We are busy with the ILAE administrators. For some reason on their site, we're not able to share sound. There's an option on this to share sound and it's not going through. So I'm sorry, until we fix that glitch, we'll just have to do it live. It's much more fun, of course, doing it live. So let's see how it goes. Let me just... Okay, can you see my... Are you all able to see?
Yes, please, we can.
Okay. So, ketogenic diet in adult epilepsy. Well, I don't know why we're talking about it. We're just big babies, right, all of us? We may have grown up into adults, but our heart still enjoys the same things. We are still a little baby inside. So really, there are some differences. Of course, there are. So the drug-resistant epilepsy in adults is a little different. that in adults, you have more epilepsy, which is secondary to head trauma, tumors, and vascular accidents. You have some of the idiopathic generalized epilepsy, but those are very few where you will get drug-resistant epilepsy. And of course, you have the large group of neurodegenerative disorders where you can get epilepsy. Many of these centers in the US and in the West, the adult centers are, I think, almost 50% or 60% looking after children who have gone, or adolescents who have gone through the epilepsy centers for the children, and now they have grown up in age. And so therefore they become adults. So we have been using this for adults right from 1996. So that's for the last 25, 26 years. And I don't think there's that much difference, except in a few key points. Compliance. I purposely put this first. That if you see that the compliance is less in adults, only 45%, this is not only for epilepsy, but this is across the board. If you look at any condition, medical condition, the compliance is low in adults. It's a much less, it's much better. Compliance is much better under the age of 5 and about the same once you come to 42%. And of course, anything with the dietary therapy is about this much. Now, what is the dropout rate? As you can see, there's a wide variation. 10 to 88% dropout with the classical, 0 to 63% dropout with the MAD. Then I went into this and saw the articles, and you will find 0% in those articles where they've just taken maybe 15 patients. Well, when you get a larger number of patients, and then you start seeing that the dropouts are more. And how many complete either a classical or a MAD? It's between 49 and 58% would complete it. But look at the anti-seizure medication. The dropout is almost the same, 42%. So it's not like compliance is only poor for diet, it's poor across the board. And the other reason why the low use of ketogenic diet in adolescents and adults in our age is because initially ketogenic diet was used in children and adults. If you look at the Livingston, probably, I think he reported around 900 patients, and most of them were adults. But then after the ketogenic diet was disused or went into disuse, the renaissance began from the pediatric epilepsy department of the Johns Hopkins and powered by the Charlie Foundation, and they targeted children's neurologists. So child neurologists were preferentially trained, and most of the data was being presented in pediatric neurology and pediatric epilepsy conferences. Also, there was a discontinuation of treatment, and due to various factors, this is across the board, adverse events, restrictiveness, effectiveness, financial problems, but the dietary treatments tended to be more difficult in adults than in children. And also it has been seen across the board that the modified Atkins diet tends to be better tolerated than the classical, because I can go out. You can go to a restaurant with your friends and have your fried chicken, which you can't do if you're on the classical, because there you got to carefully have the protein and the fat and etc. all measured. And it's so therefore it's much easier. So let's look at the comparative data of different age groups. If you see the infants, 50% control and 100. So let's first see the 100% control. So definitely more, 33% in infants, slightly less in, much less in children and adolescents, and also in adults. So children, adolescents, and adults seem to be the same. Infants is probably more. The two reasons I would say, not only the fact that compliance is easier in an infant, it's easier to catch an infant and feed him without him making too much fuss. And if he's on the diet from a very young age, he knows no other taste. So that's another reason. And the third is, of course, the fact that infants have much more severe epilepsies. They have much more frequent seizures. And because of that, the parents also come in pretty early. One of the things. Now, if you see the 50%, above 50% control, then you will see that it's almost the same. 59, 47, 53%. So the other reason here is, of course, the fact that the children, adolescents, and adults don't remain on the diet for a long enough time. So that's another reason why you have this comparative data, maybe. The less than 50% control is, again, it's approximately, I think, the same. This, I think, is a misnomer. I mean, it's a miscalculation. I've taken this from various reviews. The compliance, as you see, is much easier in an infant, and the dropout rate in an adult is much higher. If you compare the classical with the MAD, then you will see that this above seizure reduction is a little less in the MAD. So that's an important part. And we too found this. We did a very small survey of patients whom we switched from MAD to CKD, and they improved, or they became seizure-free. While when we did it the other way around, from CKD to MAD, we really didn't find much improvement. The compliance is much more in MAD. Now, if you have a higher compliance, then obviously you should get better results. So I think MAD has added to the armamentarium. And for that, we have to thank Dr. Eric Yakosov from the Johns Hopkins. In adults, what are the side effects? Because this is one thing that people always worried about.
Just one
And
second.
I was...
For her. No, let me get it ready for her. And
Excuse
then,
me, I think someone is not muted. Please, everyone else mute. So in adults, there was a worsening of seizures in 8 of 300. This is of the 300 that we've looked at as a review. And there were 8 of them who became worse. Occasionally weight loss, but in many of the adults, you want a weight loss because most of them come with a higher than IBW weight. The low density lipoproteins tend to rise, and the total your cholesterol may rise. But as I told you, this is more due to 2 factors. One is that in the West, they tend to eat a lot more of saturated fatty acids. And they also tend to not mix their fats. But if you see adults after a certain time of being on the diet, as I told you earlier, within about 6 months to a year, we found it within 6 months, these fall back to normal. Less frequently, you get hunger, diarrhea, constipation, fatigue, vomiting, nausea, which are all very easily, you can manage them. So the 2011 review showed 49% had more than 50% reduction, 13% was seizure-free, which is pretty good. Barborka, now he's another person who did a lot of work in the 1930s. He had 81 adults, of whom 47 had good improvement. Unfortunately, he did not stratify them into how many had total improvement and how many had more than 50%, because that more than 50% concept came very recently. So if you see some of the others, and really no one else has large enough numbers. So the 30 of Eric Kossoff, 14 of them had good improvement. Of Yaservenka, who's also from Johns Hopkins, 19 out of 27. So really not much different from infants, children and adolescents. So this I've just circled in red, those which have more than 20 patients. And there's a wide variation, as you can see. So the meta-analysis, let's look at the meta-analysis, and you will find that the MAD, the classical KD, and the MCT, the 13 to 70% combined efficacy rate, 52% for the classical, 34% for the MAD, and CKD, 39%, with 8% of them having more than 90% seizure reduction, And in the MAD, it was around 31%. So not much difference between whatever you are trying to do. So I have kept it purposely very short because I don't think there is much of a difference. And I've been using it for 25, 26 years. But there are two main differences. One is that adults don't come very often. They keep doctor shopping and doctor hopping. And the second is to maintain them, and to maintain them on a diet is not easy. They are very, very fastidious and pickers of food. In fact, I had one patient who left the ketogenic diet within just 3 or 4 days. And he said, I would rather doctor die of epilepsy than eat this food. So it is a big problem. And we really have to sort this out. It's not going to be easy. I think MCT is going to help us a lot. We are working on that. We are working on something else because we found that MCT, the tolerance is not very good when you go to the high amounts required in adults. We are working on a liposomal MCT. I hope to get that out soon. We've just had the first batch out, but we got to do a lot of tests on that. The liposomal MCT would probably, we would not have the side effects of the GI side effects and the tolerance problem that we're having with MCT. Having said that, I think now we are more or less on time. We have completed a few minutes early, so we can have more of Q&A. I'm sure a lot of people want to ask Q&A, both to Samar and Sumita, and very few to me, because I don't think many of the attendees really attend to adults. They're all mainly children, neurologists. So I'm handing it over to Shenaz as the moderator, and please, Shenaz, go ahead.
Thank you very much, Dr. Janak. It was an excellent presentation, and I feel very strongly that we have been using it very in the last 10 years, at least in pediatrics. And my adult colleagues are still quite in the dark about the ketogenic diet. They just write a prescription saying start ketogenic diet, and it doesn't work like that. So I don't have, because I'm on this side, I don't have any questions, and I had requested, Sonam, can you share the questions to me if there are any?
Yeah, Dr. Shanaz, I've shared the questions with you.
Just let me see.
Can you just go through your chat? I've sent it to you.
Just a second. Actually, I'm having problems connecting, so
You want me to share it to you on WhatsApp?
Can you do that? Yes, please. Because I've logged on my data, and my connection at home is very poor.
Give me 1 minute, I'll share it to you on WhatsApp.
Yes, please. Yes, please. In the meantime, maybe I can ask a question. Is that okay?
Yes, definitely. So the answering questions are already in the question Q&A box. So you can go there and you can ask some questions in the meanwhile.
But Shenaz, you can begin with whatever you want to ask while you go through that. Dr. Shenaz, are you having any problem? Dr. Shenaz seems to be logged out. So with the permission of the speaker, should I begin?
Yes, doctor.
I'll begin. So let's just begin with the first of the questions. This is for Dr. Samar. At what age can you initiate KD in neonates and infants? Are there any specific guidelines?
While I'm reading, I found in the Epilepsy Foundation, there was in 2000, I think in April 2015, there was a guideline has been published in infantile spasm, but I didn't go through it, but I think there is a guideline. However, what age, as I mentioned in the lecture, it's as early as 6 weeks, you can start it.
The next question is, what ratio should you use for infants who are admitted in hospitals?
Well, according to Dr. Kosov recommendation, 3:1. The classical one is used in the infants.
Dr. Samar, can I just add something?
Yeah, sure, doctor.
I find that the ratios I need for infants is much less. And I've talked also with Dr. Eric about this, that
Right.
I really don't agree with him.
Right.
I'm sorry not to agree with him. We are using in some infants as low as 1.25 and 1.5. So
Right.
what we basically do is, what is the least ratio at which I can achieve a urine ketone of 4+ throughout the day? And we find that the ratios for infants is much less than that for children, adolescents, and adults, where you
Right.
can rarely use the low ratio.
Right.
Okay, the next question is, at what level of triglyceride and cholesterol should you defer or stop the KD? This, I think, is for Sumita. Is it for you?
Yeah, I don't know. I think there will be other talks about this.
I think the dietitian should be the one who's actually answering this question.
Okay, so we'll defer it, but until we come to the side effects.
Yeah,
right. Yes.
The next is also for Sumita. At what age should we start ketogenic diet? In children is already answered. Is it available commercially?
Yeah, the products that we use are products that are available commercially. The formula that we use is ketonia that we actually import from Korea. Yeah, and lately we have a local company that produces MCT powder. I don't really think it's an age indication, but products are available commercially in my country at least.
Can I add something?
Yeah, yes, definitely.
So when we began, nothing was available, commercially. And what we did is we just used what is available in the market as raw products, which included your soya powder, then came almond powder, along with oil. And then we would put the carbs in the form of vegetable or fruit. And we're using that even now. And we find that then what happens is that you don't have to worry about whether this food which is commercially available, is it always available? Does it go off the market at times? And if I'm in a small village, how will I get all of this? So I think we should be very flexible. And all the products which are commercially available are also expensive. That's another thing we have to keep in mind, the cost of all this. The next again is for Sumita, but it would come in the side effects. Can KD affect the growth and the development of small children?
Definitely, the diet can affect growth. That's why monitoring growth parameters are very important, and tweaking the diet with regards to calorie comes into place. But I think this will be spoken about in next talks. I think today or tomorrow. Yeah.
Is there any modified ketogenic diet that can be done at home or ambulatory? I think all the ketogenic diets are done at home.
Yeah.
I don't think, we don't admit anyone. We don't even admit a child of 2 or 3 months. What about you, Dr. Summer? Do you admit that?
We do, yes. We do admit them for at least 3-4 days.
Okay, I don't admit anyone. I mean, we're available on the WhatsApp all the time, 24 hours. So we really don't admit them because it becomes expensive. What about you, Sumita? Any?
Yeah, I admit the younger ones, the infants,
Exactly.
or at least 4 to 5 days, want to stabilize. No, I go up on the ratio quite fast and make sure there's no side effects. We're achieving good ketones, and once parents are happy, they get used to the concoction and preparation, then we let them go back. But the bigger ones are all done as outpatient.
Yes.
Okay, the next question is about experience of KD in mitochondrial disorders. This will be taken up by Dr. Anita Hegde when she speaks on mitochondrial disorders. So we'll postpone that. After that is how long should we apply ketogenic diet for epilepsy in adults? It's the same as any other anti-seizure medication. Once the patient has no seizures for about 2 to 3 years and the EEG has normalized, then we start taking them off. And when we taper it over a period of time. The next is really for dietitians, what type of protein sources one should give patients, whey protein, casein or soy, that will be again taken up by the dietitians. The next is about an MCT diet. Is MCT diet the only one that is effective in adolescent PKU suffering from drug-resistant epilepsy? Sumita, I think that actually comes to you.
Unfortunately, I have no experience with the use of PKU. Yeah. I don't know.
I too don't have any experience with PKU. You really don't see it that much, but I don't see why you should be using only MCT. You can use any.
Yep.
Someone has talked about MCT oil and what percentage of MCT oil should be given. This will be taken up when we take up the different types of the diets.
Yes.
And exactly how much MCT can we give? What is the role of IGF-1 in the case of epileptic encephalopathy? This I think is for Dr. Summer because she is talking more on epileptic encephalopathies.
Yeah, I have no clue actually.
Yeah, so IGF-1 is
for the growth
in all epilepsies, obviously more in the epileptic encephalopathies, and ketones has a very potent effect on it. I went through very rapidly, but you would have seen it in one of the slides. And just at this time, I can tell you, let me inform everyone, all those who are here and all those who have not come, that all the talks and the PPTs will be recorded, so you can at any time see it later on the ILAE site. This is again for summer in a hospital setup where blood ketones are checked and infants are wearing diapers. How often should we check the blood ketones and how many times should it be checked?
Yeah, that is being done by our dietitian, and I guess she's doing it every 4 hours in the first 24 hours, and then I think she's doing it 3 times daily.
Is that 3 times daily only as long as they are in the hospital or
In
even
the
when
hospital.
they go home?
In the hospital, and when they go home, she's following them up in the clinic. I think she's doing it once a day.
Once a day?
Yeah.
Wow, but that becomes expensive again. And supposing if your child is from a faraway village, for Dr. Summer, it's fine. She is in Dubai, which is a very small town.
Yeah.
But what happens in Pakistan, Nepal, Bangladesh, Sri Lanka, you don't even have the petrol to go to the hospital. And India, where you many, many miles from any keto center. So what we do is infants who are wearing the diapers, it absorbs all of that. So we tell them to put the cotton wool balls into the diapers. The cotton wool will soak the urine. When you take it off, take that cotton wool, the ball, it will be soaked in urine. and you squeeze that out, and you need just a few drops of urine. And we're doing this since ages, since 1996, and it works as well.
Can I say something, Dr. Janak?
Sure.
Sorry, I got disconnected. my Wi-Fi got disconnected. I'm really sorry about it. But the way that we do it is we put the diapers on the reverse side, so it doesn't soak, and so you can actually collect the urine sometimes in a bottle over there, and you can get even a few drops. And as you know, like you had said, this is it's very expensive for us. So we don't do it every day. Sometimes we have an average like 2 to 3 times a week max. And we also ask them to cut the dipstick into 2 so that we double the number that we have. And yes, these are very expensive. So yeah, we get them from villages and everywhere. So and the admission part, I like to admit them. So now I have a very good colleague who's working in a government hospital. So what we do is we admit them for 2-3 days just to teach them, because that part I feel is the most important part, and to measure and how to do it and see if they're doing it correctly. So we admit them in a government hospital if they're very non-affording. If they're affording, we admit them under our services, and my dietitian then goes to that government hospital. She free of charge, and she oversees the way that they do it. So that's how we do it.
Okay, can I add something here?
Yes,
So the
please.
way we do it is, luckily I have 3 full-time dietitians. They spend between 4 and 5 hours with each family. Who actually used to come here. Now, obviously, after the pandemic, since last 2 years, many are not able to come. So we do it either on the WhatsApp or on the Zoom, and it seems to work equally well. We then have a follow-up after maybe a few days, and then after a week, and then after 2 weeks, and it goes on like that. And I find that it's equally well managed, because during the pandemic, we realized people are not able to move around. There's a lockdown, and we have been able to manage new patients on the diet even during the lockdowns. The next question is about ketogenic therapy in adults, and do you need some unique supplements? Yes, of course, we have supplements where you have multivitamin, multiminerals, which make sure that you have the selenium, chromium, and zinc. These are the 3 very important minerals which are low on the ketogenic diet. And of course, your calcium. One point over here, which would come up when you talk of supplements, is to alkalinize the urine. Someone would talk about that, and we use the potassium citrate.
I'll speak about that another.
Yeah, I think everyone is using that. The next is about the biochemical parameters. What are the biochemical parameter changes before and after giving a ketogenic diet in infants? Dr. Samad, this is basically for you.
Yeah, that's again will be discussed again in the lectures of the dietitian.
Yeah.
But if they want more details, updated consensus statements of Dr. Kosov has a nice table of what the parameters and what are the changes that will happen if they want it in details, really.
Dr. Shehnaz, you want to once again take over as the moderator?
Yes, I have one question for you, Dr. Janak, and that is when you mentioned in your first session that MCT does not require, it can enter directly into the, it does not require carnitine, and enters directly into the portal, into the liver, and be utilized. So the question is that normally when you start the keto, we have all these contraindications that we think about, and fatty acid oxidation defects are one of them. Would you consider MCT primarily as the fat source in carnitine deficiencies or carnitine transporter deficiencies?
Yeah, definitely. The problem with MCT is the tolerance. There are some children who will not tolerate even, I've seen 2 ml of MCT and they have GI problems and loose motions and whatnot. Yeah, they have diarrheas. So that is one major problem with MCT. But I think once we solve that by getting the liposomal MCT, I'm very confident we'll get it out. Then this problem will be solved. And with MCT, you can give a lot of carbohydrate, much more than with the classical. It's almost like the modified Atkins you'll be able to go to, and you will get much higher ketone levels. We can get up to 1.5 to 2 ketones, which you won't get with either MAD or definitely not with LCI. So I think MCT will change a lot of things as long as we can get it out in a liposomal form.
Okay, thank you. And one more question to you again was, these adults, we see, these intractable form of epilepsies are more common in pediatrics. And they then can, over the last 20, 25 years that my practice is, I've seen these children grow up now. And so previously, 10 years ago, I was not using KD. Would it be any benefit? And now we also have genetic testing. And as Sumita was mentioning, I have 3 patients with Angelman on KD. And so they are still on KD and they are now in their adolescent age group. And they are relatively well controlled. They usually have the intractable continuous slow spike and wave of the sleep type pattern where they have these seizures in sleep. So my question to you is, number one, would it be advantageous if we start off late in these children who are now adolescents with these intractable epilepsies? And have you seen any benefit in that? Like, coming in late teens, 19, 20s, and they are severely handicapped, but having intractable seizures. And we haven't really given them KD previously.
So my first slide was that adults are only big babies. And that's my answer, that you can use it at any age. Having said that, the next was what I talked about initially, the kindling. As these seizures become more and more chronic, normal neurons around that focus, if we say that there's a focus, are going to get subsumed into these abnormalities. And the burden of epilepsy or the burden of abnormal neurons is going to go on increasing. So obviously it's more and more difficult, and that we've seen. Anyone who has uncontrolled seizures for a long time, there's going to be kindling, there's going to be more inflammation. Inflammation in turn will cause glucose hypermetabolism. If you have any periods of status epilepticus, it will. But having said that, there are some adults who do brilliantly on this. There are several of my patients who have started seizures at the age of 8 or 10 and who come to me at the age of 40, 50 and have done really well. So it's not like you can't use it. Of course you can use it, but it's not going to be that easy, and it's not going to be that, the results are probably not going to be that great.
Thank you. And so if we don't have any more questions, then I will end the session. And
No. Wait, Janak. You've not looked at the Q&A. There are still 3 more questions.
So because I can't see it, I'll just have to ask. So
Okay.
More,
So
WhatsApp.
So if KD increases epilepsy, rarely, that is, it does. We've seen that. How long should one run the diet to understand that it is actually not going to once again drop? Usually we say if it is increasing epilepsy, if the seizure frequency goes up, then within 4 to 6 weeks, you should be able to know that this is not going to settle. It should have gone back to the baseline. So I hope that answers yours. Does olive oil have any significant role in KD? I think it's as good as any other oil as far as oil is concerned and as far as ketogenic diet concerned. Has anyone routinely used the ketone breath analyzer? I have not. I don't know anyone else in Asia who has used it. And I think if you can get urine examination is so cheap, why are we going to go in for a ketone breath analyzer? And I think in Asia, at least, people don't mind, collecting urine of a child or something like that. So now we are going to have a break, and we will come back in 10 minutes. We are going to check with ILAE again why we are not able to play the audio. I hope we'll be able to set that right. So a few other things I wanted to tell you. This 10-minute break is basically for you to have some tea or coffee or something and get some of the caffeine in. So you'll not only be awake, but as I told you, caffeine is something that can be used along with ketogenic diet. And at the end, whether you're logging out and not coming back for tomorrow, or if you're going to come for both the day sessions, before you log out, please go and complete the questionnaire, because the ILAE would love knowing your feedback. Okay, thank you very much. And we will come back at 12:20. So it's actually only 6 minutes. Bye, everyone.
I'm Dr. Anaita Udwadya Hegde, and I have with me